Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. The topic of today's lecture is the pathology of heart failure, atherosclerosis, and myocardial infarction. And these are the objectives of this lecture. And you can just go through it. I'll pause for a moment while I find the pointer. So these are the 6 objectives. It is in the 3 parts. The first part of the lecture is about the heart failure. Your last week's case 4. So definition of heart failure. Before the definition, what is CHF? Chronic heart failure is CHF. CF is congestive cardiac failure. These are also the different names given to heart failure. It is a syndrome, a collection of signs and symptoms in which the heart cannot generate sufficient output. That is, the cardiac output cannot be generated by the heart, and it cannot meet the metabolic demands of the tissue. So there's a disturbance of the balance of the supply and demand. This is called supply and demand. The heart cannot supply what the tissues are demanding. It is a serious condition. It is a progressive condition with poor prognosis. We can divide the causes or the etiologies in 4 groups. Etiological groups are 4. The first one is systolic dysfunction. That is, the dysfunction of the contraction. The contractile function of the heart is decreased. There's decrease in the contractile function of the heart. And the examples are ischemic heart diseases and myocardial infarction. We'll come to them at the end of near the end of the lecture. Ischemic heart disease and myocardial infarction will affect the contractile function of the heart. The second type is diastolic dysfunction. In this, when the heart has problem during its relaxation phase, it cannot completely relax. When it cannot relax, blood will not come inside the chambers, and the filling is decreased. The chambers are not completely full, therefore the function is affected. It cannot pump all the blood forward. So there is problem in the relaxation. And this occurs in these 3 conditions: fibrosis, amyloidosis, and constrictive pericarditis. You will notice that this is highlighted now and not in the PDF provided to you, if you have received it or not. So this is an important question for your quiz or the exam. So that is why you can get a MEQ or a MCQ on it. So you'll find these highlights and green stars, which are important from your examination point of view. The third is valve dysfunction. You know that if the valves are not functioning properly, naturally, the heart has to work hard, and finally a time comes when it will fail. So heart will fail if there is a valvular dysfunction. And I think there was some valvular problem in your patient number 4 also. These occurs in rheumatic heart diseases and endocarditis. Finally, rapid increase in the blood volume. If suddenly the blood volume or blood pressure is increased suddenly, quickly, then even the normal heart can fail. Rapid, sudden increase in the blood volume or blood pressure will lead to heart failure, even in a normal heart. You must have done the cardiac cycle. There's a full lecture quite in detail, but I'll just briefly tell you the pathogenesis of chronic heart failure. When there is there is systolic dysfunction. That means there's a pump failure. The heart cannot pump the blood forward, which will lead to low cardiac output. We also call it forward failure. It cannot send the blood required forward, so it is a forward failure in the systolic dysfunction. These are the 4 conditions which can start this. Coronary artery disease, CAD is coronary artery disease. Cardiomyopathies, diseases of the muscles of the heart. Hypertension, and number 4 is valvular diseases. You are aware of this. So when these diseases are present, then they will change the model of the ventricle. There's remodeling of the ventricular tissue, and there will be left ventricular dilatation. Although there is some compensation also, which will come to that. So there is left ventricular dilatation and left ventricular dysfunction. When there is left ventricular dysfunction, there will be a decrease in the ejection fraction, which is responsible for the symptoms of the heart failure. The decreased ejection fraction is responsible for the symptoms of the heart failure, as well as at the same time, the body will start activating the compensatory mechanisms to bring the cardiac output towards normal. There are 2 mechanisms. One is the renin-angiotensin-aldosterone system, which tries to increase the blood pressure and many things by increasing the fluid retention and vasoconstriction. The second compensation mechanism is the sympathetic nervous system. We'll see them a bit later, the compensatory mechanisms of the heart. So when these compensations start, the body tries to save the fluid. So ask the kidney to increase the absorption of the fluids, and the blood vessels are asked to vasoconstrict so that there is proper cardiac output and blood pressure. So these are the mechanisms. But what will they do? They'll increase the ventricular remodeling. So when the ventricle will start dilating more because now there's more fluid in the circulation. So this will be a vicious cycle will start and will cause the problems. So fluid retention will also cause symptoms of the heart failure, the edemas and dyspnea, breathlessness, etc. can occur when there's more fluid going to the lungs, and other problems start because of these fluid retention also. So this was the pathogenesis of systolic dysfunction or the pump failure. So when there's forward failure, naturally there will be a backward failure also. If you seen an accident on the motorway or anywhere, when there's an accident, in the beginning there's a stoppage of the traffic. After some time you'll see the whole traffic at the back is also blocked. So this is called backward failure. So when the heart cannot pump the blood forward, all the blood, so blood will start collecting in the ventricles. The end diastolic volume will increase, followed by the end diastolic pressure, and then from the ventricles and atrium from the heart, this pressure will transfer to the veins, inferior vena cava, and the venous circulation, the portal veins, etc., jugular veins. So there will be elevation of the venous pressure. So all this is the backward failure. And finally, when there's increase in the pressure in the veins, there will be congestion of the venous circulation. Congestion means there's more blood. This blood which is not circulating, this is getting collected, very slow circulation. So it is congested on the venous side also. So finally, all the organs are affected by the forward and backward failure. So the forward failure will lead to backward failure because the blood is getting collected, the end diastolic volume is increased, end diastolic pressure is increased, then the pressure will be transferred to the veins and the whole venous system is congested. Finally, all the organs are congested by the forward and backward failure. As I told you earlier, what are the compensatory mechanisms? I think there's a complete separate lecture on it, but you must have been given by other colleagues of mine. So the compensatory mechanism, there are two mainly. One, they call it Frank-Starling mechanism. Frank-Starling mechanism, also called Frank-Starling law, it says that when heart is dilated, when the heart dilates, there's increase in the cardiac myofiber stretching. The length of the myofiber increase. So when the length of the cardiac myofiber increases, they will contract more forcibly. Now they are long, they can contract more forcibly, and there will be increase in the cardiac output. So this is a mechanism to prevent the decrease in the cardiac output. The second mechanism is the activation of neurohumeral system. Neurohumeral system. There are three components in this compensatory mechanism. Norepinephrine or noradrenaline or norepinephrine is released from the autonomic nervous system. It will increase the heart rate. It will increase the myocardial contractibility, and it will increase the vascular resistance. This will increase the overall lead to increase in the blood pressure and increase the perfusion pressure in the peripheral tissue. So norepinephrine released from the autonomic nervous system will increase the heart rate, myocardial contractibility, and vascular resistance. The second component is renin-angiotensin-aldosterone system. This is the system involving the kidneys and the adrenals, that water and salt retention occurs, which will lead to increase in the circulatory volume. When water and salt is more in the vessels, the volume is increased, the circulatory volume is increased, and they also, renin-angiotensin also, angiotensin means increase in the vascular tone. This component will increase the tone of the blood vessels. So all these, again, they are trying to increase the blood pressure and perfusion pressure. Finally, atrial natriuretic peptide. Atrial, you understand, it comes from the atrium. Natriuretic means it is trying to increase the diuresis. It's increasing the diuresis through the involvement of, I think, sodium. So this is kind of balancing. It produces a balance between these two, and between this system and this system, through diuresis and vascular smooth muscle relaxation. It's kind of trying to balance. If only this is present, it's going to increase the blood pressure too much. So this is a kind of balance, that on this side it is retention of the water, and this is excreting the water. Diuresis means more water is lost in the urine, more urine. So this is opposite to this, but they are trying to balance each other, these two mechanisms. Morphology of heart failure, the left ventricular failure, is that you can see so thick, the wall of the left ventricle is very thick, and under the microscope you see these are the normal fibers, and these are the hypertrophic fibers. The fibers are large, the nuclei are large, and this is the hypertrophy of the myocardial fibers. At this stage, I'll put a question to you. What is the difference between hypertrophy and hyperplasia? These are very basic things. I have noticed that the medical students have very little knowledge, and this I teach my dentistry student in the first lecture, second lecture. So this is very important difference. What is hypertrophy? What is hyperplasia? And please go through it. The good students, inshallah, will look into it. So what happens in the left-sided heart failure? That there's decrease in the perfusion in the whole systemic circulation, which is supplied by the aorta and all the arterial system. There's decrease in perfusion. But on the other side, there's increased back pressure in the pulmonary circulation. So it cannot pump all the blood. The left heart failure, the left ventricle cannot send the blood to the aorta and the systemic, so it will start collecting in the lungs. So you can see the lung is edema and congestion. And because of that, the patient had breathlessness, and then this was initially taking few steps or steps, that later on it becomes when he started lying down. And he also developed the pink color sputum, that is the hemoptysis. Hemoptysis means coughing out blood in the sputum. This occurs because when there's increased pressure in the lungs, there's hemorrhages, small hemorrhages in the lung tissue. This is the microscopy. And the RBCs, they contain hemoglobin, which is converted into hemosiderin. The hemoglobin is red in color, hemosiderin is brown in color. This is done by the help of macrophages. The macrophages, they convert the hemoglobin into hemosiderin, so that is why they are also called siderophage. Siderophages are present in the lung tissue. They are also called heart failure cells. This is an important question we usually ask. Where do you find the heart failure cells? They are not in the heart, they are in the lung. So heart failure cells are the brown color macrophages containing hemosiderin present in the lung when there is increase in the pulmonary pressure, pulmonary circulation pressure. And on this side you see these are the dark black color pigment. This is the carbon. Either he is a smoker or he lives in the city. So you get these pigment in the lungs of the smokers or workers in the coal mines or the people living in the city, near the city centers. The right-sided heart failure commonly occurs after the left-sided failure, usually, most of the time. Because when there's increase in the pressure in the pulmonary circulation, the pressure will now move to the right side of the heart. From the increased pressure of the lungs, it is now coming to the right side. So this is a kind of continuation. Usually it occurs like that. But sometimes heart fails without any involvement of the left side. It occurs isolated right heart failure. We call it cor pulmonale. Cor pulmonale is the term used when there is isolated right heart failure. So these are three causes of cor pulmonale, and this can come as an MEQ for your quiz. What are the causes of cor pulmonale? And what is cor pulmonale? It is the isolated right heart failure. Morphology of right heart failure. In the left heart failure, you saw the main load was on the lung, but here the problem is on the right side. So when the right heart is hypertrophied and dilated, the liver and spleen are enlarged. Hepatosplenomegaly occurs. The liver has a very special characteristic. What happens because of the increased pressure? The central area becomes necrosed and the surrounding viable liver cells are present. So it looks like this, and the cut surface. The pathologists, they have given this name as nutmeg liver. They call it nutmeg, just like one of the nut. You could see how you pronounce it, Joza, Tayyib or Tayyib, whatever. So this is how the cut surface of the liver looks like in right heart failure. It is called nutmeg liver because there are areas of necrosis and areas of congestion around it. So that is how dark and yellow areas are present. Sometimes fat change also occurs. So this is hepatosplenomegaly. The body cavities get water in it. There's effusion into the body cavities. What are the body cavities? Peritoneal cavity, pleural cavity, and pericardial cavity are the three main body cavities. They will contain fluid, effusion in the right heart failure. The fluid will go to the feet and lower legs. This is the dependent edema, the collection of fluid. We have seen all the mechanism that there's an increased fluid, so it just gets collected in the body cavities, in the feet and the lower legs. And the neck veins are engorged. You see the neck veins are thickened and engorged and filled with blood. We call it increased JVP. JVP stands for jugular venous pulse. This is one of your ECE question, or they can ask you. So the jugular vein gets, one can note the pressure and then can say that the JVP is elevated in right heart failure. We come to the second part of the lecture, atherosclerosis. Atherosclerosis. Atherosclerosis is defined as intimal lesions. This is in the diagram, you can see intima, the innermost layer of the blood vessel, then the media, the middle one, and adventitia. So these are the intimal lesions, also called atheromas, also called atheromatous plaques, or atherosclerotic plaques. So these are intimal lesions that invade into the lumen. They invade into the vascular lumen inside, on that side, towards the inside, and then they can rupture to cause sudden occlusion. So by definition, these are intimal lesions, invade the vascular lumen and can rupture to cause sudden occlusion. We should differentiate the atherosclerosis from arteriosclerosis. Arteriosclerosis means thickening of the blood vessels, hardening of the blood vessel. Arteriosclerosis means hardening of the blood vessel, which occurs in the hypertension and diabetes and other diseases. So this is different. In atherosclerosis, we have a very special change, we all know, is the presence of fat in it. So this is the diagram to explain what is an atheromatous plaque. It has two parts, the fibrous cap, and the second part is the necrotic center. Necrotic center has cell debris, cholesterol clefts. These are the elongated cholesterol clefts. Sometimes you'll find them as called cholesterol needles. So they are elongated cholesterol clefts, and the foam cells. These are the macrophages. They ingest these fat and they develop foam. They become like foam cells. They are called foam cells. And after some time, if it remains for a long time, you get calcium also in it. So in the necrotic center, you have the cell debris, means dead cells, cells which are dead or dying, cell debris, cholesterol clefts, foam cells, and calcium. Because in the later stages, they get calcified. If you look at the fibrous cap has smooth muscle cells, macrophages, foam cells. Some foam cells are in the cap also, lymphocytes, collagen, elastin, protoglycans, and neovascularizing. All may not be present, some may be present. So there's no new vascular, means new blood vessels are formed in the cap. That occurs in, if they are large in size. In this picture, we don't see. Here we see this one new blood vessel formed at the junction of the cap. This is a new vascularization. A small new blood vessel is being formed. New vascularization can occur in the atheromatous plaque. So it has two main parts. The significance we'll see. I hope we'll come to it later. What are the major risk factors of atherosclerosis? It has been correlated with a number of risk factors. We divide them in two parts, non-modifiable and modifiable. They are fixed. Non-modifiable you cannot change. They are constitutional. They are in the person, you cannot change them, like the genetic abnormalities, family history, increasing age, male gender. These are the risk factors of atherosclerosis. They are not changeable. While the modifiable risk factors are hyperlipidemia, increase in the level of lipids in the blood, hyperlipidemia, hypertension, cigarette smoking, diabetes, and inflammation. These are modifiable. You can change them by your diet, by your exercise, by your quitting the smoking, all these can be changed, they can be modified. So the two groups of major risk factors. The next three slides I've taken from our pathology textbook Robbins are related to hypercholesterolemia, and mashallah you have a full lecture on hypercholesterolemia by my biochemistry colleagues, so I won't say much about it. Just quickly going through the evidences which suggest that hypercholesterolemia will lead to atherosclerosis. Number one, we find that the dominant lipid in the plaques is cholesterol and cholesterol esters. Number two, there are genetic defects in the lipoprotein metabolism, which will lead to increased atherosclerosis. One of them is, I'll make a question which you will see that it's different from the PDF you have received, that the question could be, in homozygous familial hypercholesterolemia, there's a defect in the LDL receptors. These receptors are present on the surface of the hepatocytes, liver cells, and also in other cells of the body. So through the help of these receptors, these cells, they take in the LDL inside their cytoplasm. So if the receptors are defective, LDL cannot be taken in by these cells, and the LDL remains in the circulation, and the level is increased and causes accelerated atherosclerosis and myocardial infarction by the age of 20 years. So in this disease, patients develop myocardial infarction at a very young age. The other evidence is that in some diseases like diabetes mellitus and hypothyroidism, there is hypercholesterolemia and premature atherosclerosis. There's a large population study, epidemiological study called Framingham's study. Framingham is a city in United States, and this study is going on for more than 75 years now, affecting 3 generations, and they are measuring their cholesterol and other factors, examination and investigations, and they have found a correlation between cholesterol, LDL, and atherosclerosis. Very strong, large study going on. Then we know that by diets and drugs you can improve the atherosclerosis, decreases progression. There is regression of the plaques due to drugs and diets, and the risk of cardiovascular events is decreased by diets and drugs. Finally, what are the mechanisms? One is that in chronic hyperlipidemia, there's impairment of endothelial cell function. The endothelial cells, they secrete a molecule called nitric oxide, which is a good molecule, and it produces vasodilatation. This is done by, and this is destroyed by, the nitric oxide is destroyed by the free radicals produced during hyperlipidemia. So when there's hyperlipidemia, there are free radicals, increased free radicals. They are also called ROS, reactive oxygen species. So these molecules will destroy nitric oxide, which is a vasodilator produced by endothelial cells. In your PDF, it is written nitrous oxide. So they are two different. The correct is nitric oxide. Anyone knows what is nitrous oxide? Okay, this is a recording. So the nitrous oxide is used in anesthesia, and it's also called laughing gas. Now you will know that the laughing gas is also called nitrous oxide, and it's used in anesthesia. But here it is nitric oxide. The other mechanism, they say that when the lipoproteins, they accumulate, they get oxidized. Oxidized LDL is formed, which is then ingested by macrophages. They convert into foam cells and produce inflammatory markers, growth factors, cytokines, chemokines, etc. Similarly, we'll see that in the cholesterol, in the plaque, the cholesterol crystals are present. They are just like needles. cholesterol crystals or cholesterol needles are present, which are danger signal for the macrophages. When the macrophages see them, they see them as foreign bodies lying in the center. So they start trying to engulf them, trying to produce inflammatory markers like IL-1 and other pro-inflammatory markers. So these were taken from the old 5-year-old book of Robbins. Many things new have come. In your biochemistry lecture, you'll know about good cholesterol, bad cholesterol. A small clip I've linked to at your last slide, a very nice 4 minutes link, which will help you understand the cholesterol metabolism. The pathogenesis of atherosclerosis is very nicely given in your textbook with a lot of pictures. So I've enlarged them and cut them in 4 or 5 slides to make you understand that they say that the theory is, again, a hypothesis, is that this is a chronic inflammatory response of the arterial wall to endothelial injury. So whenever there's injury in the body anywhere, so in this case is injury to the endothelial cells, the artery wall will produce a inflammation, chronic inflammatory response against the injury to the endothelial cells. And how this injury is produced? By hyperlipidemia, by hypertension, by smoking, by this molecule in the body called homocysteine, by hemodynamic factors, by toxins, by viruses, by immune reactions. All these are the factors that will cause injury to the endothelium. So whenever there's injury to the endothelium and the blood vessel will produce a response to that injury by producing inflammation. So what is the response to the injury? First of all, the endothelium is now injured. It cannot function normally. So the function of the endothelial cell is disturbed. One of the functions we just discussed, it produces a smooth surface so that circulation occurs normally, and it produces nitrous oxide, which is a vasodilator. But if it is not functioning normally, it will also increase the permeability. So it will not keep the molecules inside. The molecules will now start going outside the endothelium into the intima, deeper part of the intima, and in the media, etc. So there's increased permeability, and because of these mediators, the leukocytes will attach to that injured area. So there's adhesion of the leukocytes. Then the monocytes will adhere. Monocytes and leukocytes, they are all circulating in the bloodstream. Monocyte, when come inside, attach and come outside the blood vessel. When monocyte goes outside the blood vessel, it is called macrophage. The same cell will now be called macrophages or even tissue histiocytes. In the liver, they are Kupffer cells. So like that, the name changes. So monocyte in the blood goes outside the blood vessel and produce its growth factor and inflammatory mediators, etc., and they migrate outside. In the next step, now the macrophages, they are activated and they produce mediators which will call the smooth muscles from the media into the intima. So that's a very odd thing, very abnormal thing. The smooth muscle cells should be in the media, as I told you in the diagram earlier. But now, because of the inflammatory activation of the macrophages, they call the smooth muscles into the intima. And because of that, and there is also, you can see, a lot of fat. The yellow fat is also collected. And the macrophages will try to eat this fat while this is lying outside. So it will try, it's a danger signal for it and starts eating them. So this is the third stage of pathogenesis. There is increase in the macrophage activation, smooth muscle recruitment. Recruited means they are coming from the media into the intima, and lipids are collected in the vessel wall. In the next stage, you can see they are starting, both the macrophages and the smooth muscle, they are eating the lipids. Why they are here? They should not be here. So they try to remove, they try to eat it. There are also other inflammatory cells like lymphocytes. Now at this stage, if you look from the inside of the blood vessel, there are fatty streaks. You can see the lines are produced. They are yellow in color, yellow streak or fatty streaks. They are very little. The surface is not so irregular, but still smooth, but you can see some irregularity, little bit irregularity. And because of the collection of the macrophages and the smooth muscle, there is some increased movement or change in the contour or surface of the endothelium. So we call the first stage as fatty streak. And in the next step, you see that the smooth muscle will proliferate, collagen is deposited, the blue color collagen is deposited, other extracellular matrix is deposited, and you can see now the fat is not in control of that cells. They're still lying separately in the center. So there's a lot of extracellular lipid inside. So this is now a well-formed fibrofatty atheroma. Now it is more enlarged. Now it's increasing in size. Now a whole fibrofatty atheroma is formed, which contains the cap now. The cap is composed of the smooth muscle fibers, endothelium. In the center, we have the necrotic center. We have the lipid debris and the other inflammatory cells, the foamy cells, etc. Now this is the fibrofatty atheroma. So this is the second stage actually of formation of atheroma or atherosclerotic plaque. So here we can see the four stages of atherosclerosis. First stage is the fatty streak or yellow streak. You can see the very simple little bit of irregularity in the first stage. And interestingly, in this population nowadays, in the Western population, they have seen studies, this is present even in the boys and girls of 8, 9, 10 years old because of the bad eating habits. So at this young age, this disease starts, and by the age of 40, they start getting the heart attacks. The second stage is called stable plaque. Stable, now it is fixed. It has a good cap on the top, and the necrotic center is a bit low. This is more strong. It is stable. It has got a good cap. But in the third stage, what happens? The fat increases, more foamy cells, more fat, and the cap becomes thin. And the chances are it is vulnerable plaque. It can easily rupture. It can rupture, and clotting can occur on the top. When clotting will occur, it will cause the thrombosis and complete blockage of the lumen. So this is the stable plaque having a good cap, fibrous cap on it, lot of cells here, and little bit of necrotic center. But when in the next stage, in stage 3, it is unstable or vulnerable plaque. Now more fat deposits and the cap becomes thin, and it can break, the cap can break, and the clotting can occur, thrombosis can occur, and complete blockage can occur. And when there's complete blockage, the patient can get myocardial infarction. And finally, complicated plaques. So here this is the picture of the third. This is the third stage. You can see some changes are occurring. It's visible easily. You can see more yellow areas, some dark areas also. These dark areas are because of the hemorrhage and ulceration. So this is a complicated plaque. Because aorta is big, these both are from aorta. So they are large, so they cannot block the whole lumen. They have large lumen, so it cannot be blocked by even complications. The blockage can occur in the coronary arteries or cerebral arteries, not in the aorta. But in the aorta, you just see a lot of yellow color and hemorrhages, dark color of the hemorrhages. So this is number 4 is the complicated plaque. So these are four stages of atherosclerosis. You may not like this. I may also not like to show you this, but it's a part of our game to see it under the microscope. So you can see the lipid core, lot of white color, because when you make a slide, the fat gets dissolved. It cannot see them. So what color white areas are the fat. These are the needle-shaped cholesterol cliffs, and this is the other fat, and here is the blood vessel, and this dark areas are the calcification. So this is a picture near the cap and the lipid, showing all the inflammatory cells. All these dots are the inflammatory cells, calcification. This is the new vascularization, and you can identify other parts of also, but it can be a stable plaque. Later on, it becomes a unstable plaque if more fat is deposited. The common sites, abdominal aorta is the most common site, infrarenal part, where it is bifurcating because of the high pressure there, a lot of injury in this area. The high pressure comes and then divides at the bifurcation. There's a maximum atherosclerotic change in the abdominal aorta. The other common sites, of course, coronary arteries, popliteal artery behind the knee, internal carotid arteries going to the brain, and circle of Willis at the base of the brain. This is the circle of Willis, is also a good site, important site of atherosclerosis causing problem in the brain. But you can see in one single vessel, you can see lesions of different stages. So depending on how much pressure is there, how much inflammation is there. So you can, in one diagram, one blood vessel, you can see many. So we also usually give a simple question, which is the common sites, or in MEQ we can ask you give 1 or 2, 3 common sites of atherosclerosis. It is a big topic. Now we have to see the changes we have seen pathologically and how it is changed into clinical. Up till now, when we look at the normal artery, this is the normal artery, we have seen the fatty streak, just tiny yellowish color, fatty color of the blood vessel because of the changes we have discussed, that all these changes which we have just now read, little bit of lipid and more of the inflammation. Then it becomes a complete fibrofatty plaque in the second stage. And then after that, if there's cell death and degeneration, more inflammation, plaque will grow in size, and there's remodeling of the plaque and the remodeling of the other extracellular matrix, organization of the thrombi. Some small thrombi can form, some small clots are formed, but they get organized and calcified. So this is an advanced plaque. It is decreasing the size of the lumen. Now see, the lumen is decreasing, so blood is not flowing properly. And we know the patient of ours, he could walk few steps and started having breathlessness. And then when he sits down, because it's not completely blocked, after some time when the demand on the heart is not present, he becomes normal. Or he takes nitroglycerin tablets. So this is just a very early clinical picture, preclinical or early clinical picture in the advanced plaque. Now from the advanced plaque, we get the clinical picture. If it becomes more advanced, we can get 3 pictures here. One is the aneurysm and rupture. This occurs usually in the aorta when there's large lumen. Because of these changes, the wall becomes thin and balloons. Aneurysm means ballooning of the wall, and then it can rupture. This occurs in the large vessels in the aorta usually. But for our myocardial infarction, these 2 changes are important. We'll see them now. So whenever there's plaque ruptures, plaque erosion, hemorrhage, and then this formation of thrombus. Thrombosis means there's like intravascular clotting. It's a different lecture, I think, will be given to you or has been given, I don't know. So thrombosis occurs and there's complete blockage, occlusion by the thrombus, sudden blockage of the lumen, and no blood is flowing now. And that can cause the clinical features which we'll be discussing now. But sometimes clotting does not occur. Slowly and slowly the stenosis increases. The lumen is almost 10% only. This is called critical stenosis, when there's only progressive plaque without thrombosis, without embolism. So now we'll see these changes. What are the major complications of atherosclerosis? Number 1 is the most common cause of death and in the whole world these days is the myocardial infarction. We call it heart attack. Cerebral infarction is called stroke. Aortic aneurysm means in the wall of the aorta there is ballooning. That ballooning is called aneurysm, and that can rupture and cause hemorrhage and bleeding and sudden death also. Then peripheral vascular diseases means gangrene of the extremities. That decrease in the blood supply in the legs, etc., peripheral blood vessels, and a condition called gangrene occur. I hope you know what is gangrene. It's one of a type of necrosis and special bacteria. They come and make the tissue black in color. And finally, the third part of the lecture, we have gone through 50 minutes. So I thought I'll give you this dictation file, so that or recorded file, so you can hear it anytime you like, and not to push everything in 45 minutes. So myocardial infarction or ischemic heart disease, what is the difference between the two? Ischemic heart disease is the main umbrella. It's the main group of diseases. Ischemic heart disease. Ischemia means decrease in the blood supply. Ischemia means decrease in the blood supply, IST. So it's a big group of diseases. There are many diseases under the heading. Myocardial ischemia is the decrease in the blood to the heart. The myocardium is the heart muscle. So decrease in the circulation, blood supply to the heart is called myocardial ischemia. It's an imbalance between the cardiac blood supply, that is perfusion, versus myocardial demand, that is oxygen and nutrition. The heart muscle wants more oxygen, more nutrition, but in the condition of ischemia, it cannot get enough blood supply and perfusion. So the disturbance between the supply and demand. Because of this narrowing of the blood vessels, small blood vessels, lumen is small, so the myocardium cannot get the blood to pump properly. So that is ischemic heart disease. And myocardial infarction is death of the muscle. Myocardial infarction is one of the syndrome. In ischemic heart disease, there are at least 3-4 here. The mild one, this angina pectoris. Our patient has angina also. There was in one of the cases, I think it's case 4, there is angina. Angina means pain, pectoris means chest. Angina pectoris occurs when there's decrease in the blood supply to the myocardium, but if it's mild only, there's no death of the muscles. If the patient sits down, takes a rest, takes medicine, then there's no infarction, there's no necrosis. Then there's chronic ischemic heart disease or heart failure, and there is sudden cardiac death. All these are the syndromes of ischemic heart disease. Whenever there's decrease in the blood supply, the muscle can die. It's myocardial infarction. Or muscle does not die, but only temporarily there's decreased pain in the chest. Or there's slowly heart failure, or sudden death can occur without even pain also. So all these are the syndromes, types of ischemic heart disease. In 90%, greater than 90% of cases, atherosclerosis is the cause of ischemic heart disease. So it's so important, atherosclerosis. So how to understand this? This is a normal blood vessel showing all these 3 layers, intima, media, and adventitia. After atherosclerosis, there's some narrowing of the lumen. This is the initial phase. We call it fixed coronary obstruction. In this case, there's just typical angina. They call it typical angina, means patient is walking or taking steps and then suddenly gets pain due to exertion or walking. He sits down, he takes medicine, it's okay. In this situation, there's no death of the muscle. So this is the typical angina called fixed coronary obstruction. Then this stage goes into the next stage, in which there is deposition of the disruption of the plaque. The plaque here is smooth, here it is disrupted. The surface gets ulcerated because now it's increasing in size. The plaque is disrupted, and because of the disruption, platelet will aggregate. The platelet will come and try to fill the gap. After the platelet they get attached, they can just heal and cause increase in the size. There's just healing. But because of this healing, there's severe fixed coronary obstruction. Now this is increased in size. Only small lumen is left. So the disease is chronic ischemic heart disease. Still, there may be not complete death of the cells. Slowly and slowly this thing is happening. This is severe fixed coronary obstruction after healing. But the main problem starts when this plaque disruption goes into these two stages. There's thrombosis. When thrombosis occur after platelet aggregation and plaque disruption, when thrombosis occur, this is very serious, because the thrombus or clot will suddenly block the blood vessel. So the mural thrombus with variable obstruction, sometimes it is completely blocked, sometimes variable blockage, or these can break down. The thrombus, part of the thrombus when breaks down, it is called embolus. All these are it's very difficult for us to cover. So in this stage, patient will have unstable angina. He will have pain, but he may not be relieved by resting. This is called unstable angina or acute subendocardial myocardial infarction. Sorry, I was busy with those. So you see that when there is thrombosis with variable obstruction, there will be unstable angina and little infarctions just under the endocardium. They are called subendocardial myocardial infarct. Or if it is completely blockage, then it can be sudden death. Or it could be sudden death when this embolus. Embolus means the clot breaks down from here and goes into the circulation and blocks and cause sudden death. So these are acute coronary syndromes. This was one of them. The other one is that the thrombus completely blocks. In this case, you see acute transmural myocardial infarction or sudden death. So these are all the stages and the pathogenesis, how it occurs. First of all, if there's disruption, platelet will deposit. Either there will be complete healing, but lumen will become small, and there will be chronic ischemic heart disease. But if there's thrombus formation, this thrombus can be blocking just part of it, and there will be unstable angina or little bit of subendocardial infarction or sudden death when that thrombus breaks down, becomes an embolus, and blocks completely in the deeper tissue, in the peripheral blood vessel. Or it can directly, completely block this lumen, and it is called occlusive thrombus, and it will cause heart attack or sudden death. So all these are acute coronary syndromes under the heading of ischemic heart disease. Now from the ischemic heart disease, we go to myocardial infarction or heart attack. This is the main final part of the lecture. Already 1 hour has passed in the recording, but don't worry, you can see it at home whenever you want. So in myocardial infarction, there's occlusion by the thrombus. Complete blockage of the blood vessel will cause myocardial infarction or heart attack. This is the necrosis of the heart muscle due to ischemia. Necrosis is the word used when you see it under the microscope. Death of the cell is called necrosis. And infarction is also death of the cells at a gross level, at a larger level. And necrosis at the level of microscope, but they use it interchangeably. So it occurs at any age, but even 10% before the age of 40, and after 65 it's more, 45%. Blacks and whites are equally affected. Men at larger risk than females, But after menopause, the older women have more common cause of death. Ischemic heart disease is the common cause of death in the older menopausal woman. So after menopause, the rates become same. This is the morphology. You see that we use in the post-mortem, sometimes we have problem or difficulty, then we use this dye to stain the muscle, and then you can see there's loss of red coloration because of the dye. Will confirm that this was a myocardial infarction. And here you can see this is white area is telling us that there's an old infarct also, long time back, and it's now fibrosis. There are evidence of old infarction, and this is a complication. This is the hemorrhage in this heart which has caused sudden death of this patient, and this is an autopsy slice of the heart, autopsy or post-mortem slice of the heart, gross examination. Under the microscope, we call it coagulative necrosis. Coagulative means you can identify that these are the muscles. These are muscle fibers, but all dead, and between them are the acute inflammatory cells, or these are acute inflammatory cells. Later on, you see the cells, some of the cells and fibroblasts are coming, and the chronic inflammatory cells are coming. So these are fibroblast, elongated one, and the rounded are the chronic inflammatory cells. And then in the last stage, fibrosis is more visible. This blue color is a special stain, trichrome stain, showing the collagen fibers. Now the fibrosis is occurring. You may get this question as a sequence. We can change the sequence of these 4 steps to give you an MCQ, giving the right sequence of changes that can occur in the microscopy of myocardial infarction. We have given such question previously, so I remembered it for you. And it's too long now. Should we go through this clinical features? You know very well. Most common is the severe crushing chest pain or pressure. I heard one of the consultants saying that the patient feels that an elephant is sitting on the chest. I don't know if, may Allah save us all. So they feel that an elephant is sitting on the chest. So it radiates to the neck, jaw, and epigastrium left arm. It can remain for a few minutes to hours, and it's not relieved by rest, not relieved by the nitroglycerin tablets. Other features, clinical features, are that 10 to 15% patients will have atypical signs and symptoms. They can be entirely asymptomatic. Patient will have high myocardial infarction without any pain, especially in the diabetics and older patients. Other atypical features are rapid and weak pulse, diaphoretic. Patient will have sweating. This is quite common. I saw many patients, they develop sweating and during myocardial infarction, dyspnea, nausea. All these are these atypical clinical features or other features of the myocardial infarction. And finally, this is just a list of myocardial infarction, nothing for me to say, just to read for you. Cardiogenic shock can occur, and because the heart cannot pump the blood forward after myocardial infarction, we call it cardiogenic shock. The other shocks, if you remember, anaphylactic shock due to allergies, then bacteremic shocks can occur due to bacteria, septicemia, etc. So this is a cardiogenic shock. Greater than 40% of myocardial infarction can go into the shock. Mitral valve regurgitation can occur when the papillary muscle is infarcted. These are the papillary muscles which are holding the valves. The mitral valve is held by these papillary muscles. So if they get infarcted, there will be mitral valve regurgitation. Myocardium can rupture in 10 to 15%, but that is of course fatal. Then right ventricular infarction will lead to right ventricular failure. And all these are the rare chances of complications. I think that is all. And it's a lecture which I could not shorten to 45 minutes. So we can take this as a recorded lecture. You can get a rest during my lecture slot from 1:15 to 2 o'clock. You can take a rest and listen to my lecture anytime in the evening or tomorrow whenever you are not hypoglycemic, not busy, inshallah. Of course, I'll need the du'as from all of you. Any questions, you can send message to me through WhatsApp, inshallah. And this was, I was telling you, in the reference and resources, mainly I took it from our textbook, Robbins, Basic Pathology. It's now 5-year-old, and these are the pages. If anyone is interested, I can send the PDF of these pages to you later on, if you want. And this is a clip which will make you understand a little bit of cholesterol metabolism, LDL, HDL. But I hope you get a good idea from your own lecture by your tutor of biochemistry. And it's a vast field now. It's a lot of new things are coming. And because it's so important, and a lot of research is going on. Thank you very much. Ma as-salama.